in various figures in the guides. For the DIP joint, this positional technique is demonstrated in figure 1620 for the DIP joint. What again you will do is ask the patient to, go ahead and raise your hand up, to maximally flex and then extend, and ensure that she's aware that you're going to be testing this joint again for maximum motion but not cause pain, and ask her to maximally flex and measure the flexion of the DIP joint. Again, being careful to ensure that the axis of the goniometer is over the position of the DIP joint that you're measuring. And again, you would do this 3 different times. For time's sake, what I frequently do is go ahead and measure all the flexions of the joints first, and then I'll go in and do the extension measurements later. So again, same technique, but going ahead and moving the axis of the goniometer now to the PIP joint and measuring flexion. And then moving on to the MP joint. Trying to ensure stability again in the goniometer to ensure, again, accuracy and reliability of your measurements. Extension would be similar as in the thumb. You place, again, the device on the volar aspect of the digit. Again, the axis of the goniometer for motion over the joint that you're measuring. Go ahead and extend. And then come back. And the remaining digits of the hand involving the DIP, PIP, and MP joints would be measured using the same technique. Another methodology that can be used for measuring impairment of the hand and digits is to measure total active range of motion impairment. In this case, what you would do is ask her to maximally flex the digits of the hand and measure the flexion measurements with the goniometer of each joint. Then what you would do is ask her to maximally extend the digits and measure again each extension measurements or maximal extension measurements of each joint. As discussed earlier in greater detail, one critical technique for measuring sensation in the hand or the upper extremity is using a 2-point discriminator to measure sensation loss in the hand. The next area for measurement discussion is the wrist. As referenced earlier in the video, there are various sizes for goniometers that can be used for measuring different joint measurements. In this case, you would want to pick the appropriate size goniometer to allow for proper stability and examination. Obviously, in this case, the larger goniometer most likely will be too large to measure accuracy and reliability for the wrist. Depending on the size of the patient, one could certainly use the intermediate size goniometer or even the smaller size goniometer. In this case, I think it's reasonable enough to pick the smaller goniometer for this patient. So there are 4 components to measuring wrist motion: dorsiflexion or extension, palmar flexion or flexion of the wrist, radial deviation, and ulnar deviation. For the first motion measurements, you would want to go ahead and make sure that you have the proper landmark again, making sure that the goniometer is placed in the proper axis for measurement. In this case, again, for the wrist, you would want to make sure that you place the goniometer in parallel to the radius and ulna, and then the other axis in parallel to the hand. So for palmar flexion or flexion of the wrist, you would ask her to maximally flex her wrist and take the appropriate measurement. And again, you want to try and stabilize the goniometer to ensure accuracy and reliability, and perform 3 measurements assuming that those measurements are within 10%. For extension or dorsiflexion, you would do the same thing, asking her to maximally extend the wrist or hand. And again, doing this 3 different times. Excellent. The other motions of measurement, I'll tilt her arm so that it can be better visualized in the video, is to measure radial and ulnar deviation. In this case, again, you want to make sure that you have the proper axis placed with the goniometer again over the wrist, and place this again in the proper axis or alignment with the radius and ulna, and then of the third metacarpal of the hand. And go ahead and ask her, if doing ulnar deviation, ask her to maximally deviate and measure that. Similar to other measurements as we've described, if there is inaccuracy or unreliable measurements in your eyes, you can go on and do 3 additional measurements, if need be up to 6. And for radial deviation, the same technique. The next area of motion measurement discussion is going to be the elbow. In this case, there again is 4 areas of measurement: flexion, extension, supination, and pronation. The goniometer again needs to be chosen for the between the various sizes, and in this case I'm choosing the intermediate size goniometer for this patient. Similar to the other techniques, you would ask her to warm up, and then again make sure that she's performing within her capabilities and not harming herself. For flexion extension of the elbow, you would ask her to go ahead and extend her elbow first off, and again align the axis of the goniometer with the elbow joint to ensure proper placement. I usually have her flex a little bit, and then align again with the humerus, and then again with the radius and ulna. And so place that there, and then have her go ahead and maximally flex and take that measurement, come back down, go ahead and again repeat 3 different times. And then for extension, again, it's the same technique, where you would ask her, go ahead and maximally extend, and go ahead and extend, and then extend. As you're aware, sometimes the patients may lose extension with certain injuries in the elbow. In this case, again, you don't want to force their extension beyond possibly a flexor contracture in the elbow, because it may cause harm or pain. Supination and pronation measurements in the arm can be done by a goniometer, in which case you would go ahead and have her place her arm in a thumb up position and measure the motion measurements for pronation and then supination, taking the measurements, again aligning up with the long axis of the ulna and the radius, and then measuring the amount of supination and pronation loss. So go ahead and pronate, and then come back up. Go ahead and pronate, and come back up, and then come back down. The other methodology that can be used that may even possibly give a more reliable technique for measuring supination and pronation is using an inclinometer. In inclinometer measurements, there are various types of inclinometers as was described in the spine section. In this case, I have a digital inclinometer, which I would place into the palm of the hand, thumb up again, position, 0, the position, and then have her pronate, and then take that reading, and then do it 3 different times. Same method for supination. Go ahead and go in the other direction. In this case, for ensuring accuracy and reliability of the measurement that you're taking, you want to try to stabilize the elbow to ensure that you're measuring just supination and pronation measurements. Next component for measurement is the shoulder. In this case, there are 6 components for measurement: flexion, extension, abduction, adduction, and internal and external rotation. Again, it's important to make sure you have proper landmarks for measuring the shoulder in motion, and this includes ensuring that you have the proper size goniometer, in which case, for the shoulder joint, which is one of the larger joints, I'll use the larger size goniometer. After a proper warm-up technique, and again discussion about making sure she's providing maximal effort without causing her harm, I'll have her disrobe and place her in a position side away from me, with the goniometer again placed over the axis of the shoulder to ensure accuracy and reliability. Have her goniometer aligned with the humerus, and have her go ahead and measure 3 motions for flexion. Go ahead. And then come back down. Again. Come back down. And then again. And then come back down. For extension, you do the same technique. Again, making sure the axis stays similar, stabilizing this other side of the goniometer with the humerus, and going ahead. Okay? And you want to make sure you go directly backwards, not to the side. Perfect. And again. Perfect. Next, I'll have her shift positions to show for abduction. We're going to place the goniometer again so that the axis point in the shoulder joint is consistent with the center of the goniometer. And I'll have her abduct, thumb out. Have her abduct with, again, this aligned with the humerus. The other area is adduction, in which case I'll have her face me. And again, align the goniometer again with the shoulder joint for proper axis. And I'm going to have you go ahead and bring your arm across your body like this, keeping your arm. There you go. Go ahead and come back down again one more time. Go ahead and go. Come back. Then go. Come back. And then go. Perfect. The measurement for internal external rotation again is done with the patient facing to the side from you. And what you want to do is have the patient abduct her arm at 90 degrees at the shoulder. Again, placing the axis of the goniometer at the shoulder joint consistent with the level of the humerus. And in this case, what you want to instruct the patient to do is just move around the axis of the humerus, stabilizing that goniometer, and going ahead and going downward. Go ahead. One more time, go. Okay, and then the opposite direction for external rotation. And placing your arm again like that. The other critical factor here, and it goes with all the upper extremity motion measurements, is you want to measure both sides of the injured patient. This is critical for making sure that you are measuring the normals of the patient. The guide describes different methods for ensuring the normalcy of the patient as a baseline measurement. In this case, if the uninjured side is not measured, then you may not have accuracy of normal measurements for that particular patient. Another important concept in measuring shoulder motion, especially in someone with persistent pathology or impairment, is if someone cannot get to 90 degrees of abduction for measuring internal or external rotation, the examiner should go ahead and do the best he or she can, meaning try to instruct the examinee to abduct as best possible, and then going ahead and performing the same internal or external rotation measurements as best possible. Go ahead and going down. For completing the neurologic evaluation of the upper extremities, as discussed earlier, one would want to go ahead and perform sensibility testing with the Semmes-Weinstein or a monofilament testing, the two-point discrimination tester, reflex changes, and circumferential arm measurements for atrophy. Specific to the determination of sensory loss, not described earlier, is with digital nerve injuries, it's important to ensure that you're measuring the ulnar and the radial side as a differentiator for your sensory loss, if there is any, because the AMA guides does differentiate between a loss transverse across the digit versus longitudinal if it's only on either the ulnar or the radial aspect of that digital nerve. For circumferential measurements, one should go ahead and use a tape measure to measure around the maximum circumference of the forearm in centimeters, and then a maximum circumference around the biceps or the humerus area. As discussed previously, grip strength is a component for impairment rating, although, as noted in the guides, AMA Guides Evaluation Permanent Impairment 5th edition, it is rarely used for measuring impairment. And if it is used, then the proper methodologies for measuring accuracy, reliability, and consistency must be followed.
When assessing the shoulder, it's important to look for